Good afternoon. I'm Dr. Jack Farr at OrthoIndy. This afternoon, we're going to be discussing our orthobiologic program. It's relatively new to OrthoIndy, but it's been around for years, and I've been in the field of orthobiologics for over 20 years. We're going to be admitting more and more people to the seminar. During that time, I'd like to just give you a little bit of my background. I went to Rose-Hulman Institute of Technology, where I had a degree in biologic engineering. That sort of spurred my interest in science and mechanics, and that certainly merges well with orthopedics. I had problems with my own knees. I had a very bad family history for knee osteoarthritis, and so even in my residency, I was looking for different ways to impact people's lives and hopefully alter the course of osteoarthritis. Unfortunately, at that time, the science was really lagging behind what was going on in the clinical field. And so I reached out to a couple of the preeminent surgeons in the world, and really their programs were just in infancy. In fact, that was starting it with osteochondral allografts at that time. In the mid to late 1990s, cell therapy was born with Carticel. I became involved with that, and then everything just blossomed after that. So that, which is cell therapy, we then went into meniscus transplants, osteochondral allografts, got involved with multiple different clinical studies. And at that time, we started looking at other biologics. And that's when the biologics such as PRP and cell therapy, as we'll discuss later on. More and more people now are coming in. I'm going to let Ashley admit them. So we're going to go back to the intro screen, and then I'll be back in about 2 minutes. You'll see at the bottom of the screen, there's a little icon that says chat. If you cannot hear me, please just tell us that you're unable to hear, and we'll make sure we correct the audio. I think as more and more of us are doing these Zoom meetings, we find out that there's certain little idiosyncrasies with each meeting. Little bugs pop up, but we'll make it through. Ashley, have you admitted everybody that you can see? And then we'll go ahead and start. And that way, this will be recorded. So if you want to go back and review it or forward it to someone for their interest. Want to just expand it? So once again, I'm Jack Farr. I have a specialty in knee preservation and cartilage restoration, and within that is the field of orthobiologics. I've personally been doing this type of surgery with preservation and even the non-operative portions for over 25 years, and I've gotten my partners involved. And so for the past year, we've been developing and fleshing out our OrthoIndy biologics program. So this is the outline. First of all, we'll go over what it is, why might someone need it, the backgrounds of orthobiologics and the program, and then looking at some of the orthobiologic options. certainly the one that rolls off everybody's lips, it seems, of PRP and stem cells. And I'll tell you why what we're typically dealing is not stem cells. So our program, our fundamental goal of our orthobiologic program is to provide cutting edge treatments, but with a sound scientific background. There's a lot of cutting edge treatments that unfortunately are past scientific backgrounds, and we'd kind of like to restrain, pull back, and just offer what's available and what's ethical and what's backed by science. So this is not advancing. There we go. So what are orthobiologic therapies? Orthobiologics use natural tissue-derived products that orthopedic surgeons and others will use to help injuries heal potentially quicker and may delay major surgery, such as an arthroplasty or a joint replacement. And what are these substances? Certainly everyone has heard of cells. There's different components that make up different tissues and liquids of our bodies, including proteins, glycoproteins, complex carbohydrates. These are all natural to our body. When orthobiologics are used, they may enhance the healing process by decreasing inflammation, decreasing pain, stiffness, and then allowing the patient's ability to improve function. What they are not stem cells. The scientist that actually coined the term is Dr. Arnold Kaplan at Case Western University. So he was a basic scientist, and he's in a lab taking cells. These are cells that are derived, typically they were initially either from fat tissue or from bone marrow, and they were from the one portion of the body. So you have the ectoderm, the endoderm, and in between, which are muscles, bones, cartilage, that's the mesoderm. So these were building block cells. So he called them stem cells because in the laboratory, he could actually take these cells and add different chemicals and make them turn into muscle, bone, cartilage. But in fact, in the body, these cells don't behave that way. And so he sort of, I don't know if any of you have written an email and then the next thing you do, you say, oh, I didn't mean to send that. And then you try to retract the email. It's impossible to retract an email. It's there forever. So MSCs or mesenchymal stem cells have been around now, that term, for more than 10 years. And, got into different magazines. It was on the front covers on, doctors could take these cells and make a mouse's ear or what have you. And the next thing, well, maybe they can make hearts, they can make cartilage. So there was a lot of hype. There was a lot of encouragement. And the one term that everybody kind of jumped out as was a stem cell, because these are cells that actually can make any cell in the body. So are there stem cells? Yes, there are stem cells, but these are up the cascade. The cells that we're actually dealing with, the ones that we get out of this tissue, the mesenchymal tissue, these are pluripotential cells, so they can make certain tissues along lines. Now that's their potential in a laboratory. But when used clinically, when they're taken out of the bone marrow or fat or even amnion, these cells do not behave in that manner. These are actually called now medicinal signaling cells. And what Dr. Kaplan is using the word medicinal signaling, he's saying these cells, which are actually cells that live around the microvascular, they're called parasites, these actually will go out and influence the environment. Now, if injected, let's say, for example, a knee, these parasites or MSCs are injected, they can influence the tissue that they're injected to actually use that own or the host's true stem cells or pluripotential cells, but these are tissue specific. So if they're injected, say, for muscle, they're going to direct muscle-derived, quote, host stem cells that can do potentially something with the muscle. So the idea of these cells that are injected actually going in and creating cartilage in the United States, that's not possible. Now, there is ongoing research. Some of it is now coming to the United States that's FDA approved, and that's the only way in which these types of cells can be used to regenerate tissue. That was originally performed in Kuala Lumpur, Malaysia, by Dr. Saw, now Dr. Adam Ans in Pensacola is trying to replicate that, but that is using cultured or many numerous cells. These are not available in the United States today outside this FDA trial. So I know you're going to be tempted to use the word stem cell. I'm just going to use cell therapy because yes, the cells do inhibit inflammation. They do actually change the perception of pain. So they're going to improve comfort and function for a lot of patients, but they're not going to make a new tissue. There was a study that we actually helped participate in 2012, 2013, that we published in 2014, and these were cultured stem cells. Unfortunately, right now, the FDA does not allow clinics to culture them outside of a participating study. The bottom line was in this study, we were actually trying to regenerate a meniscus, sort of what everybody thinks these quote stem cells can do. Well, two things came out of our study. One, the amount of tissue that was regenerated was very minuscule. So from a functional standpoint, it did not adequately regrow a meniscus. However, if you looked at the patients that had mild to moderate arthritic symptoms, those patients had marked diminishment in their symptoms, and that lasted out 2 years during the duration of the study. So, can these things help comfort and function? Yes. Are they regenerating tissue, at least currently in the United States? No. Who might benefit from this type of therapy? For my patients, most of them are patients with osteoarthritis. So osteoarthritis is the degenerative form of arthritis. So we're not talking about rheumatoid arthritis, psoriatic arthritis, etc. This is the wear and tear arthritis that it's the most common, affecting over 52 million people in the United States. So with this, what type of patient with osteoarthritis? Certainly you can see the patient with a partial knee replacement. I have a partial knee and a full knee in me, and I wanted to try to avoid those as long as possible. But unfortunately, if you're bone on bone, those patients don't do as well with these types of tissues. Let me see if I can. So in this example to the left, that's a full knee replacement that certainly a lot of people would like to avoid, and I can understand that. On the right, you can see one has a partial knee and one does not. If the one that does not have any metal or plastic in it, you can see the joint space is narrowed, but there's still a joint space. So we would call that moderate osteoarthritis. So if you have some remaining joint space, the potential for improving after these types of treatments is much better. If you have bone-on-bone changes, then the probability of having a significant improvement is not zero, but it's much lower, as some of the pain is actually coming from the bone and not from the surrounding tissues that are the ones that are most responsive. What are other types of treatments? Tendonitis and soft tissue injury. Certainly tendonitis is very common. I see at the knee, quadricep tendonitis. In this case, this is an example of patellar tendonitis. You can see the bone that's in front of the femur. That's the patella. And attaching to that, there's a dark tissue. And then at the top of the dark tissue, there's an area of whiteness. That whiteness is deterioration of the tendon. Many people will call that tendonitis. It's really tendinosis. It's sort of a blunted type of degenerative process of the tendon, just like arthritis is a degenerative process of cartilage. This is a degenerative process of the tendon. The body tries to actually restore it and regrow, and it is a muted, blunted response, and it's just scar tissue. So these patients with this type of prolonged or chronic tendonitis are typically not going to respond to physical therapy and oral anti-inflammatory medications. Now, whether or not a single injection into this area is going to have a positive response is still under study. There's been multiple studies, and there are positive and negative studies, but if you look at the risk-reward ratio, attempting some type of a biologic intervention before going to surgery, I think most people would opt for that. Certainly stay tuned because there are ongoing studies, and as you'll see, all the different treatment options are not the same, just as all PRP is not the same. So here are the options. We're going to go through these. We'll talk about PRP and then the different types of cell therapies ranging from bone marrow aspirate, adipose tissue, and placental-derived tissues. So PRP, that's extremely common. You see that advertised on TV, and PRP is not PRP. What do I mean by that? You have to be very specific on how it's prepared, because the two main broad categories, one is if there are less platelets, and another one is if there are more platelets. And the second is how many white cells are in them. They've found, at least for most of the studies that are involved with osteoarthritis, it's important to have fewer white cells, as the white cells can cause inflammation. So it's not as important for osteoarthritis to have very, very large numbers of platelets, but it is important to have fewer white cells. And so for our osteoarthritis patients, we will use a preparation that has increased platelets, but not as much as another prep. So increased platelets and very few white cells. So these are ones in the orthopedic literature would show that they have a positive response for treating osteoarthritis symptoms. Does it regenerate tissue? No, but it does improve symptoms. Symptom relief is typically on the order of 6 months, could be 4 months, could be 8 months. And how is it working? The thought process is that it's decreasing the inflammatory environment, which contributes to the pain of the knee. So for ones with more white cells, those are the ones I might use. So the PRP with a higher white count. So I want to have an initial inflammatory response. Why would I want that? For a healing response, that is part of the inflammatory cascade that then goes on to a healing cascade. So for tendonitis, I will typically use one that has a higher white count. So once again, this is an evolving type of a process, and it's important to use science as your basis. So tissue and cell therapies, bone marrow aspirate, adipose, and placenta. These are with FDA, 2 different product, manipulated or non-manipulated. Currently, the FDA is sort of giving everybody a timeout. So they're not going to really enforce these until July of 2021. Things are really going to change then. The rationale for using these, there's certain chemicals that are anabolic that build things, certain ones that tear down are catabolic, and these influence that synovial, cartilage, and bone environment. Key issues, certainly language is important. We don't use the word stem cell, we're using cell therapy. So are you a candidate for osteobiologics? If you have osteoarthritis or a tendon injury, has an anti-inflammatory medication failed to adequately relieve your pain? Did bracing fail to work? Has physical therapy failed? And has cortisone failed? If you answer yes to those questions, then you are a potential candidate for orthobiologics. So what's the cost? Unfortunately, Medicare and insurance companies do not pay for PRP or these other cell therapies, and so these are all self-pay. On our website, you can see our actual costs to the patient. Fortunately, we've been able to structure this so we have some of the lowest costs in the country. So I'm happy to answer any questions. Certainly, you can feel free to enter your questions in the chat section. Also, I'd like to inform you that not only will this be recorded, but within an hour, you'll be receiving an email with our contact information. So you can contact us through that link or through www.orthoindy.com, Jack Farr. There's the telephone number. I'd be happy to see you in the office, or we can chat via email. If we have any time for questions, Ashley, do we have questions that we might want to answer?
Just previously submitted ones.
Okay, well, here's a couple. So first of all, it says, will it help my back pain? As you know, I'm a knee surgeon. We do have multiple excellent spine surgeons and also non-operative physiatrists who treat back pain. The key, whether it's knee pain, back pain, hip pain, shoulder pain, is not just to throw something generically at, quote, the pain. You have to find out what the pain generator, and certainly there are so many different pain generators in the back. You know, is it a bony problem? Is it a disc problem? Is it a facet problem? Is it a nerve impingement problem? So once you identify those, our physiatrists are able to inject any place in the spine that you're having a specific mechanical or biologic problem, and then you can discuss with them which of these biologics might be the best. But that goes for knee pain as well. People say, is it good for my meniscus tear? We have to know what the meniscus tear is, why you have it, where it is, how old you are, what are the other injuries. I'll give you an example. If it's a degenerative meniscus tear, the PRP injection may decrease the overall pain because, wow, it's great. We have less inflammation. Did it heal the meniscus? No. When we're doing meniscus repairs, I will use some of these cell therapies, specifically bone marrow aspirate concentrate. We clot this, and this is in the literature, that clotted blood. And so I'm just using sort of even a more concentrated application of that to augment healing. So that's an example where in selective areas, we're able to use this to augment. Thank you very much for attending. Once again, I'll be happy to discuss further.